Good day, everyone. So this will be our session on focus assessment with sonography for trauma, otherwise known as FAST. By the end of this session, you should be able to define what is FAST, know its advantages and disadvantages. You should have an idea on how the procedures perform and the appearance of the different ultrasound images, and later on its clinical application and significance. This is an example of the ultrasound unit that we use. We have three basic probes classified as to shape. The convex probe is the one that is used for examination of the abdomen. Sector probe for examination of the four-chamber view of the heart and the pericardium. And the linear probe, which is used for examination for the presence or absence of pneumothorax in cases of extended FAST in evaluation of the anterior chest wall. Just to give you a glimpse on how the ultrasound image is produced, the ultrasound wave is produced by the piezoelectric crystals in the probe and is based on either reflected or transmitted sound waves. Based on the density of the organ being examined, if the organ or structure is dense like calcium, majority of the sound waves will be reflected, or if the organ or part of the structure being examined is less dense or fluid containing, majority of the sound waves will be transmitted. And based on this, the data will be transmitted or fed to a computer, and the computer will generate the image. And the reflected image will be seen as hyperechoic or white areas with posterior acoustic shadowing, as in this gallstone. And the transmitted images will be seen as black or anechoic area, like the bile in this gallbladder. So you should note that the ultrasound examination has a narrow field of view compared to a CT scan procedure in which there is a 360-degree image of the entire abdomen. The ultrasound makes use of a narrow field of view, and that's why it's quite operator dependent. In cases of air-containing organ, usually the sound waves are poorly transmitted through air. That's why often there is scattered sound waves which produces artifacts, and these artifacts are the basis for examination of the pneumothorax, presence or absence of pneumothorax in the chest in cases of extended FAST exam. So, focus assessment sonography for trauma is an emergency procedure. Usually the ideal setup is that the ultrasound should be located at the bedside in the emergency room. The objective is to detect free intra-abdominal or pericardial sac fluid collections in cases of blunt or stable penetrating trauma. And the extended FAST objective is to detect the presence or absence of pneumothorax. To date, these are the three procedures that are currently available for the evaluation of fluid collections in the abdomen. Diagnostic peritoneal lavage is the most invasive. CT scan is usually the procedure of choice for stable patients. And the FAST examination, as we are discussing, is the procedure of choice for unstable, hemodynamically unstable patients. This table shows a comparative evaluation of the three procedures. And you'll notice that CT has the most diagnostic ability, higher than the DPL and the FAST exam. However, based on ease and speed of the procedure, safety because of the presence of radiation, and repeatability is far outweighed by the FAST examination. That's why FAST examination is commonly being considered as the procedure of choice for emergency room evaluation of free intra-abdominal or pericardial fluid collections. Okay, so the primary indication of FAST is usually to evaluate stable or unstable blunt or penetrating trauma for the presence or absence of free intraperitoneal fluid collection. In cases of pregnancy, it is usually indicated because CT is usually radiation emitting and diagnostic peritoneal lavage is usually invasive and may be therefore difficult to do in cases of pregnancy. Hypotension of unclear etiology is likewise indicated. You must remember that FAST helps to determine or triage patients requiring emergent laparotomy versus patients who may be monitor or await slower, more definitive studies like CT scan or diagnostic peritoneal lavage. Okay, the benefits of this procedure is that it is non-invasive. It can diagnose fairly, accurately, presence or absence of fluid collections in the abdomen, does not require nephrotoxic contrast material, intravenous contrast material as we do on CT scan. Of course, it's non-radiation emitting procedure. It can be done bedside in the emergency room setup. The repeatability is good, and it usually can be integrated in the primary and secondary trauma survey of the patients. Okay, in pregnant patients, it's very useful because of the non-radiation emitting procedure. It usually reduces the need for CT and diagnostic peritoneal lavage procedures. And of course, it's highly specific for detection of free fluid. A positive FAST examination usually is indication for exploratory laparotomy, especially in the setting of a hemodynamically unstable patient. But unfortunately, you should remember that a negative FAST exam cannot rule out the need for laparotomy. These are the common drawbacks of the first procedure. It has a limited ability to detect organ injury, especially the liver, pancreas, or spleen, which is usually easily detected by CT. Well, it usually requires a 200 cc volume of free fluid collection for it to be able to be detected accurately. And the intraperitoneal fluid is quite difficult to classify as to whether it's really hematoma or can be ascites, urinoma, or secondary to peritoneal dialysate in cases of patients with peritoneal dialysis. Of course, we are discussing that it's operator dependent, and sometimes in cases, obese patients or non-cooperative patients, especially pediatric patients, are difficult to examine. Well, this shows that in adults, usually the specificity and sensitivity is higher compared to pediatrics. That's why, as a result, if clinically suspected, a negative FAST examination may still warrant additional intervention, like CT scan or diagnostic peritoneal lavage. So this is a schematic diagram on how the procedure is performed. The probe is placed in 4 areas of the abdomen: the right upper quadrant, left upper quadrant, subxiphoid region, and the pelvic region. The philosophy behind the FAST examination is that fluid will gravitate or pool in the most dependent areas of the abdomen. Okay, these are the four views that are usually done in the procedure to evaluate intraperitoneal or pericardial fluid collection. So as we have discussed in the schematic diagram, the hepatorenal recess or Morrison's pouch is evaluated in the right upper quadrant. Splenorenal recess or Collar's recess is evaluated in the left upper quadrant. Subxiphoid pericardial window evaluates the four-chamber view of the heart and the pericardium. And the suprapubic window, which is in the scan in the pelvis, evaluates the retrovesical pouch in the male and the cul-de-sac or pouch of Douglas in the female. This is the probe placed in the right upper quadrant, and this is the expected image that you will be encountering. So this is, to orient you, this is the liver, the right kidney, and usually there's a potential space between the liver and the right kidney, which we call as the Morrison's pouch. And normally, no fluid can be seen, or no black area can be seen in this region. Only a thin layer of fat created by the fat surrounding the liver, the perihepatic fat, and the perirenal fat surrounding the kidney. This is an example of a free fluid collection, an anechoic area insinuating in the hepatorenal angle, which is an abnormal fluid collection and constitutes a positive fast examination. Okay, so this is the probe placed in the left upper quadrant, and to orient you, this is the image that is produced. This is the spleen, the left kidney, and there is a potential space in between the spleen and the left kidney, which we call as the splenorenal angle or the Collar pouch. It has a potential space. Normally it is just lined by a thin layer of fat coming from the spleen and the perirenal area. And this is an example of a positive fluid collection in the splenorenal angle. Notice the thin line of anechoic focus, which constitutes also a positive fast in this setup. So again, this is the normal static image of that normal Collar pouch or normal splenorenal angle. Now this is the schematic diagram of the retrovesical or rectovesical pouch in the male and the retrouterine pouch or pouch of Douglas in the female, or sometimes they term this as the cul-de-sac. And these are the areas in the pelvis that usually contains free fluid collection in the pelvic region. So this is the scan where the probe is placed in the suprapubic region of the patient to evaluate the rectovesical pouch in the male or the cul-de-sac or pouch of Douglas in the female for presence or absence of free fluid collection. So these are real-time images, and this is an example of a normal rectovesical area in the male, wherein there's only a thin line of fat coming from the urinary bladder and the perirectal fat. This is an example of a positive fast examination, wherein there's an anechoic fluid collection in the rectovesical pouch in the male and the pouch of Douglas or cul-de-sac in the female. You'll notice if the fluid volume is increased, it may involve the anterior portion of the uterus, as in this case. Okay, this is an example of the probe placed in the subxiphoid region to evaluate the port chamber view of the heart and the pericardium. So this is the area of the pericardial sac, which is only a potential space actually, with a very thin fluid collection. And this is an example of a positive pericardial fluid collection. And in the setting of trauma, this may be secondary to a hemopericardium and may later produce cardiac tamponade if not attended to. So this is the schematic diagram for an extended or EFAST, in which the probe is placed on each side of the chest in the midclavicular line. Usually a linear array or linear probe transducer is used, and this is to evaluate the presence or absence of pneumothorax. So this is the schematic diagram of the normal lung in the long axis view, and this is the actual real-time ultrasound. You notice that the comet tail artifact brought about by the scattering of the sound waves in the normal aerated lung parenchyma can be noted, and the normal sliding pattern of the parietal and visceral pleura noted in a normal lung with no evidence of pneumothorax. The sensitivity specificity of this procedure is higher in comparison with the chest radiographs, which is only about 28 to 75%. This is a schematic diagram of a long axis view in which there is presence of air in between the parietal and visceral pleura. And this is the real-time scan of that diagram, in which there is absence of the sliding pattern of the pleura, and there is absence of the comet tail artifacts that is brought about because of the presence of intervening air in the pleural cavity. So this is an example of a positive extended FAST with evidence of pneumothorax. There are cases in which the pneumothorax is only on one side or may be loculated, in which there is an intervening normal parietal and visceral pleura. So in this case, there is what we term as an absence of lung sliding on the abnormal side, and this is the normal side in which there is presence of lung sliding. So this is what we term as a pneumothorax with a lead point, in which there is a point in which there is a transition between the sliding portion and the non-sliding portion of the parietal and visceral pleura. So this is also an example of a positive EFAST with a lead point. So this is the algorithm that we use to evaluate blunt abdominal trauma. Usually, if the patient is hemodynamically unstable or hemodynamically stable, a FAST exam is the procedure of choice. If the FAST exam is positive in unstable patients, usually laparotomy is indicated. However, if it's negative but there is continuous instability of the patient, a repeat FAST or a diagnostic peritoneal lavage may be considered. In stable patients with positive FAST exam, usually CT scan is indicated for evaluation of other forms of solid organ injury. And for negative, serialized exam may be done, or CT scan may be done for further evaluation of these patients. For AC evaluation, useful FAST calculators are now available at certain websites, and all you have to do is fill up the corresponding boxes as to whether there is absence, presence, or equivocal fluid collection on all four areas that you have taken up, and usually there's a recommendation that will be noted at the bottom. And this is usually can be done to improve efficiency of the procedure. So in summary, FAST is an emergency procedure done for fluid assessment in the intraperitoneal and pericardial compartments, for evaluation of blunt abdominal or stable penetrating abdominal injury in trauma. Because of its repeatability and the ease of procedure, it far outweighs computed tomography and diagnostic peritoneal lavage. The fluid collections can be evaluated in the right upper quadrant, Morrison's pouch, left upper quadrant, Collar's pouch, pelvic rectovesical pouch in the male, and cul-de-sac or retrouterine region in the female. For the pericardial fluid collection, it's in the subxiphoid region, and for extended FAST in pneumothorax, it's in the midclavicular line of both anterior chest. So for additional readings, I recommend to consult focus assessment sonography for trauma in Radiopedia, and there's a journal in RSNA entitled FAST for radiologists and for medical students as well. Okay, I guess that's the last slide, and thank you so much and be safe.